Hello, welcome to today's presentation by the North Florida AIDS Education and Training Center. Today's presentation is entitled HIV Pre-Exposure Prophylaxis in Florida. I'm Taryn Buckley, Project Manager at the North Florida AETC. Before we start today's event, I have a few housekeeping items to go over. If you're listening in by computer, make sure your speaker button is turned on. If you're listening by phone, please turn your speaker button off. If your phone line is not muted, it should have been as you entered the room. If it isn't, please press *6 now to mute your phone line. Today's event is scheduled for 1 hour, including the question and answer period at the end of the presentation. If you need proof of attendance for your employer or for self-reporting purposes for CE, please email us at aetc@medicine.ufl.edu for a certificate, or you can simply reply to the email that you got with the login information for today's event. You may submit questions for the speaker at any time during the presentation by typing your question in the Q&A pod located at the very bottom of the screen, right beneath the pod with the presentation. Your submissions will go directly to the speakers and hosts, not to other participants. Questions will be addressed after the presentation if time permits. Any unanswered questions due to time constrictions will be addressed via email to webinar participants. A copy of today's PowerPoint presentation can be downloaded from the Files pod located on the lower left-hand side of the Adobe Connect room. You'll also see that there is a file in there that includes our PrEP and PEP pocket card, our most recent version of the pocket card. That file is also located in the Files pod on the bottom left-hand side of your screen. Thank you for joining us today. So I'd like to introduce our speaker today. Our presenter is Dr. Zoe Muller. Dr. Muller is a faculty member of the North Florida AIDS Education and Training Center, a partner of the Southeast AETC, and is also a clinical assistant professor in the Division of Infectious Diseases and Global Medicine at the University of Florida in Gainesville, Florida. She practices general infectious diseases, taking care of HIV-infected patients at Shands at the University of Florida. Dr. Muller's specific interests include HIV provider education and the prevention and management of HIV infection in adults. As a faculty member of the AETC, she's currently involved in lecturing on pre-exposure. A file in there that includes our PrEP and PEP pocket card, our most recent version of the pocket card. That file is also located in the Files pod on the bottom left-hand side of your screen. Thank you for joining us today. So I'd like to introduce our speaker today. Our presenter is Dr. Zoe Muller. Dr. Muller is a faculty member of the North Florida AIDS Education and Training Center, a partner of the Southeast AETC, and is also a clinical assistant professor in the Division of Infectious Diseases and Global Medicine at the University of Florida in Gainesville, Florida. She practices general infectious diseases, taking care of HIV-infected patients at Shands at the University of Florida. Dr. Muller's specific interests include HIV provider education and the prevention and management of HIV infection in adults. As a faculty member of the AETC, she's currently involved in lecturing on pre-exposure prophylaxis, opportunistic infections in HIV patients, as well as maintaining and editing our pocket cards, including opportunistic infections and HIV/AIDS treatment guideline resource. Dr. Muller is board certified in both internal medicine and infectious diseases. She currently heads our practice transformation project that works with both Azalea and neighborhood medical centers. So thank you for joining us today, Dr. Muller.
Hi everybody, good afternoon. I just want to extend my warm welcome as well. I know we have quite a few people on the call from various backgrounds, and I'm looking forward for the next hour to impart a little bit of information regarding pre-exposure prophylaxis, or PrEP, for the prevention of HIV. Just before we get started, I do not have any financial relationships with any entities to disclose, and I will not be talking about any off-label use or investigational products during the next hour. So over the next hour, I hope to accomplish various things. I'd like to identify national and state trends in HIV. I'd like to help us identify, counsel, and provide HIV pre-exposure prophylaxis, or PrEP, to patients who are at high risk of HIV acquisition. I'll talk a little bit about some resources available for providing PrEP and provide a little bit of information on billing. And I'd like to round off by talking about current trends that we see in PrEP use today and potential options that we may have for the future. So to get us started, I have some data here from the CDC just to give us an idea in terms of a national level about HIV distribution. So this is some data collected and compiled from 2014, and it describes HIV infection among adults and adolescents across the United States. You can see the areas kind of in the darkest purple here representing the highest rates of HIV infection, and you can see, of course, Florida colored in a dark area. Okay, so really HIV is essentially an epidemic here in Florida. So some facts before we get started from the Florida Department of Health. Where does Florida stand in relation to the rest of the country? So in terms of newly diagnosed HIV infections in 2014, it ranked actually second in the nation. In terms of newly diagnosed AIDS cases, so those with CD4 counts of less than 200 at diagnosis, it actually ranked number 1 in the nation. And overall, in terms of persons diagnosed and living with HIV, it ranked number 3. Okay, and you can see the distribution in terms of race and ethnicity that we have on the far right. Really, it was the African American population really carrying the bulk of these diagnoses, followed next by the Caucasian, and then finally the Hispanic population. So I've included the next few slides because I think it's important to know a little bit about epidemiology, because when we start thinking about who we want to offer PrEP to, it's really important to know what groups are really at risk, okay, so we can correctly identify our candidates. So for the data compiled from the CDC, again from 2014, we look at the distribution of HIV amongst adults according to sex as well as race and ethnicity. And what you can see here is that for both males and females, it's really the African American population that ranks in at number 1 in terms of new diagnoses and infections. This is followed next by the Caucasian or white population, and finally the Hispanic population. And you can see this holds true for pretty much males and females. In terms of what risk categories represent the highest risks of transmission, you can see all that yellow there represents male-to-male sexual contact, or the MSM population. So really representing the highest risk of infection in that group. Followed next by heterosexual contact for both males and females. And coming in third, we look at the IV drug abusers for both males and females. So really our 3 highest risk groups when we want to think about, in the back of our minds when we see patients who may be great candidates for PrEP, we really want to think about the MSM population, heterosexually active males and females, and the IV drug abusers. So what do we have in terms of HIV prevention strategies? We have various interventions, whether they be biomedical, behavioral, or structural. Biomedical interventions is what we're going to focus on. They're basically medical approaches that we have available to prevent infection, to decrease infectiousness, and to reduce overall susceptibility. So you can see we have a lot of options available within this subcategory. Of course, pre-exposure prophylaxis falls into this group. But we also have various other options. So antiretroviral therapy, that holds true for the whole test and treat concept. We know that getting patients on retroviral therapy early on can reduce viral load, and if the viral load is undetectable or extremely low, the chance of transmission is similarly low. Contraception, this includes things like condoms, whether it be for males or females. Diagnosing and treating sexually transmitted diseases or STIs, okay? Injection safety for the IV drug abusers, PrEP, of course what we're talking about today, as well as post-exposure prophylaxis, or PEP. So how important is PrEP? Well, important enough to be cited by the Obama administration. So the National HIV/AIDS Strategy, or the NHAS, which some of you may have heard about before, was basically an approach in order to combat the HIV epidemic which we're currently seeing. It's a set of primary goals that were put forth by the Obama administration. They were recently updated in July 2015, meant to take us and carry us over until 2020. Part of their primary focus was to reduce the number of new HIV infections, and the administration actually cited PrEP as a real top priority as part of this initiative. Other two goals noted here is to increase access to care and optimize health outcomes for people living with HIV, as well as number 3, to reduce HIV-related health disparities that we currently see today. So getting to the meat of the presentation, what essentially is PrEP? So PrEP is for individuals who do not have HIV, but who are at very high risk of acquiring it. It's the concept of taking antiretroviral therapy to prevent them from getting HIV, and it's meant to really be part of a comprehensive prevention plan. It's not something that's meant to be used in isolation, and it's something we'll talk about moving forward in terms of the other points of discussion that we really want to have with patients when prescribing this pill. So just a question to get us started, and I'd like everyone to participate. So pre-exposure prophylaxis, or PrEP, involves taking daily pills composed of, and you can see the choices we have there. Is it emtricitabine and tenofovir, what we know as Truvada? Number 2, emtricitabine and tenofovir alafenamide, which we know as Descovy. And then 3 and 4, emtricitabine plus tenofovir plus dolutegravir, or emtricitabine plus tenofovir alafenamide plus dolutegravir. If you all want to take a moment to vote. Okay, so I think we have the results in, and it seems like the greater proportion of everybody seems to have gotten this right. So the answer is indeed number 1, emtricitabine and tenofovir, which is what we commonly know as Truvada. Okay. So let's talk about this a little bit more. So the components of Truvada, emtricitabine and tenofovir, are part of the nucleoside reverse transcriptase inhibitors. When we talk about treating HIV infection, we have various drug classes that target different points of the HIV life cycle. And you can see them listed here. Okay, so we have the NRTIs, which is what we'll be talking about now. We also have NNRTIs, protease inhibitors, fusion or entry inhibitors, integrase inhibitors, some of the newer medications that are out there. And then we have various enhancers, things like ritonavir, cobicistat, as well as a variety of new combination pills. So just a little bit of biology and biochemistry to give us an idea about exactly where Truvada works. So if you can imagine the HIV life cycle, if you want to picture HIV being the green molecule, HIV is a single-stranded RNA molecule, but in order to actually infect the CD4 cells or the white blood cell, it needs to convert itself to DNA. And it does that by using its own enzyme called a reverse transcriptase enzyme. And it essentially makes a copy of its RNA into DNA. So if we talk about Truvada acts on this step, and they act by inhibiting that enzyme so that the DNA copy can essentially not be made. Okay, and that's step 2. Both those drugs are going to interact at that step. Okay. So getting us to another poll, something to think about. So Mr. P is a 35-year-old MSM who has been taking Truvada for PrEP. He has heard about a newer formulation of tenofovir that is safe for his bones and kidneys. He asks about changing to this newer formulation since he assumes it is the same medication, only better. You recommend to A, continue Truvada, 2, change to Descovy, which is the emtricitabine and tenofovir alafenamide or TAF formulation, or 3, change to Descovy but will require more frequent HIV testing and monitoring. I'll give you all a moment to think about that. Okay, so I think we'll close up the poll here. Okay, and so everyone seems to have gotten, most of the people seem to have gotten the right answers, so the option here is to continue the Truvada, so that's number 1. And we'll talk about why the other options may not be valid just at this point in time. So some of you may have heard about TAF. TAF is a fairly new medication on the market. So TAF basically stands for tenofovir alafenamide, okay, and it's a new prodrug of tenofovir, okay. So TDF, or tenofovir disoproxyl fumarate, is the current component that we now had in use before, and it's the current component of Truvada. So the differences between the two happen in terms of conversion. So in order for these prodrugs, they have to be activated into the active form of tenofovir, that's TFV, and that happens typically at different points. So with TDF, for example, the activation to tenofovir occurs primarily in the plasma, and you can see that's at the top of the diagram here. And so with a lot of tenofovir circulating in blood, that's what goes ahead to act on the bones and the kidneys. If you look at the lower part here for TAF, you can see that it's actually a lot more stable in plasma, and that the activation to the active tenofovir form really doesn't happen until it's inside the cell. What does that mean? It means that you have less tenofovir circulating in plasma, which means that you have less impact on the kidneys and less impact on the bones. And of course, because most of the activation happens inside the cell, the dose that we're using is actually significantly less. So for TDF, we're using a 300 milligram, but for TAF, we only require 25 milligrams. Which brings us the question then, can we use TAF for PrEP? So a few studies have been investigating this, and one of the studies that we had, a phase 1 study with only 8 women, so a very small trial, was looking at the concentrations of TAF in various tissues after a single dose administration. Okay, so they gave a single dose of TAF and they compared it to giving a single dose of TDF, and then they quantified the concentrations of the active forms in various tissues. As expected, the tenofovir was a lot lower in the plasma, okay, which we got from the previous diagram, and it was a lot higher inside the cells. The issue that comes up is that when the concentration of tenofovir was measured in mucosal tissues, it was actually 20 to 90% lower than patients that had been given the TDF formulation. Okay, and in actually 83% of samples, tenofovir was not actually detected after TAF administration. So the issue here is a dosing issue. We are as of yet not certain what is the optimal dosing of TAF that would be needed to actually be protective for PrEP. So lots of studies ongoing right now, but as of yet it is not a licensed indication for PrEP. Okay, so it's not a direct exchange. So does PrEP work? Of course, if something is going to be approved by the FDA, we want to make sure that it's safe and that it has a good efficacy rating. And so various PrEP trials have been done. These have all been randomized, double-blind, placebo-controlled trials looking at high-risk individuals. Most of these studies were modeled after the same formulation, where patients were randomized to receive either Truvada as a PrEP indication or a placebo, and the outcomes in terms of new HIV infections were recorded as results. So if you look at iPrex and Partners PrEP, the first 2 studies here, you can see very favorable responses. So in the iPrex study, the primary focus was on the MSM population, which we know, as mentioned before, is a very high-risk group. They were randomized to receive either Truvada versus a placebo, and they found that those in the Truvada arm that were receiving PrEP had a 44% risk reduction in HIV acquisition as compared to those receiving the placebo. The Partners PrEP trial, a huge landmark trial, looked at heterosexual men and women in serodiscordant couples, which means that one partner has HIV, one partner does not. Again, randomized to receive either Truvada or placebo. This study was actually stopped early because the results were so overwhelmingly favorable. There was about a 75% risk reduction in HIV acquisition in those that were taking Truvada as a PrEP indication. If you look just a little bit lower towards the last 2 boxes, 2 studies there, FemPrep and Voice, I just want to call your attention to those because if you look at the results column, you see that there was actually no effect. So both of these studies were done in women, again randomized to either receive Truvada versus a placebo. And these studies actually were stopped early due to medical futility. And this is going to highlight a very important point, which I'm going to ease into here on the next slide, is that adherence is critically important. If patients are not going to be taking the medication every day as indicated, it's not going to work. Okay, and so you can see in the studies that failed where no effect was found, so no efficacy could be assessed, the drug detected overall was less than 40% in FemPrep and less than 30% in the VOICE trial. So this is going to be an important thing to talk to your patients about when we start talking about PrEP use. So in terms of prescribing PrEP, I like to divide it into 4 basic steps. This is how I approach my patients. The first thing I like to do is to assess risk. So, start off by identifying those candidates which you think PrEP may have a use in. And if you think back to the earlier part of the presentation, those at-risk groups, perhaps the MSM population, heterosexual men and women who may be high risk, and we'll talk about what high risk means, and the IV drug abusers. Once you've identified potential candidates, you want to make sure that each person is eligible. And this usually involves a set of lab work that needs to be done, and will go exactly in what we routinely order when starting patients off. Then of course, once you start PrEP, you need to think about follow-up. Okay, so follow-up is something that's going to need to be done consistently every 3 months. And we'll talk about what we want to order at each follow-up and what we want to be discussing. And then at the back of my mind, I'm always thinking about discontinuing PrEP. Okay, so PrEP is not something that's meant to be lifelong. It really corresponds to the periods of life when you're at highest risk. And of course, this may change over a person's lifetime. So just to kick us off in terms of talking about point 1, another polling question for you. So for which of these patients is PrEP a consideration? A 35-year-old IV drug abuser who is not sexually active, a 25-year-old African American homosexual male with multiple partners, a 20-year-old heterosexual female with multiple partners, a 56-year-old white bisexual male with multiple partners but who uses condoms, or all of the above. Okay, so it seems, wait for everyone to vote.
It's my passion. That's why I work with Cox Business. While you might be surprised how much technology...
Okay, so I think we can end the poll. And that's exactly right. So about 82%, almost 83% of you had the right idea. So PrEP is actually an indication for all of the above individuals. Okay. So who are our candidates? So PrEP is licensed by the FDA, so these are all Class 1A recommendations for the following individuals. So sexually active MSM, heterosexually active males and females, this includes serodiscordant couples, as well as the adult injection IV drug users. So one of the things I frequently ask my patients, a lot of patients will come into you already knowing a little bit about PrEP, hearing about it from their friends, hearing about it from the news. The first thing I like to do is I like to ask them, why do you want to start PrEP? Or can you tell me what you already know about PrEP? And I think this is important because it can clear up any misconceptions right off the start that people may think PrEP will provide, okay? And it also gives you a starting point to have the discussion based on how much knowledge somebody already has about it. Moving on from that, I then like to assess their exact risk. So patients will have different risks on the spectrum. So I like to ask, do you have sex with men, women, or both? Also important to ask what type of sex they have. Is it oral sex? Is it anal sex? Are they the top? Are they the bottom? How many partners have they had? And it's important to try to qualify that a little bit in terms of, maybe in the last month or the last 2 weeks. How many times have you had sex without a condom? Also a very important question. And if they forget to use a condom, what exactly is the reason? Is it due to alcohol? Is it due to drugs? Is it due to other kind of risky behaviors or attitudes? Had they ever had a previous STI? So remember that the presence of one sexually transmitted disease can indicate the presence of another. And not only that, but certain STDs can actually facilitate the transmission and acquisition of HIV through damage of the genital mucosa. And finally, I like to ask if patients have ever had an HIV test before. Do they know their status? Do they routinely check their status? And what do they know about their partners? Is it something that they normally talk about in their discussion? So step 2. Eligibility. So once we've identified our candidate, we need to make sure that PrEP will be safe for them. The first thing that we need to do is ensure that they are HIV negative, okay? And not only that, but that they have no signs or symptoms of an acute HIV infection. We want to make sure they have a normal renal function because of the tenofovir component, okay, of Truvada. We'd like to make sure they're not on any contraindicated medications, and this usually refers to other medications that could potentially affect the kidneys. We want to know their hepatitis B status, and that's important because if they're naive, we may want to vaccinate them. But if they had something like active hepatitis B, we need to be careful with Truvada. Truvada treats active Hep B. The issue is not starting the medication, but the issue comes up when we suddenly have to stop it. If we suddenly have to stop it, patients risk an acute Hep B infection or flare, which can be quite severe and fatal in some cases. So it's always important to know, starting out, what their hepatitis B status is. So asking a lot of questions today. So poll 4. A 23-year-old MSM patient comes to your office wanting to start PrEP. He has multiple partners but states he never uses condoms. He has last had unprotected sex about 7 days ago, and he obtained his baseline labs and an HIV test earlier this morning in anticipation of starting therapy today. His labs are not concerning and his HIV screen is negative. Overall, he feels okay, but he does say that he thinks he may have the flu. He's got some muscle aches, some fever, a little bit of fatigue. Based on this history, do you recommend starting PrEP today? I'll give you all a moment to think about that. Okay, so I think we're ready to close the poll soon. Okay, so interesting distribution here, and I'm glad this question is in because it's something that we'll definitely talk about. So the right answer here is no. So we would want to hold off starting PrEP today. And the reason for this is because, to some extent, we always worry about acute HIV infection. So how does acute HIV infection present? Well, it presents almost like the flu, okay, like any other viral illness. So quite often patients can have fever, may have some weight loss, just not feeling great, some myalgias, they may have a rash, they may have swollen nodes. And it's important to basically tease out these symptoms because if patients are infected early on, the regular screening test that we use to pick up HIV, which means use of the HIV P24 antigen and use of the HIV antibody, only appear later on in infection, at least by day 16, okay? So early on, patients may just have manifestation of these symptoms, and the screening tests may be negative, just because it's simply too early to pick it up. So what do I like to do in patients like this? I'll either order an HIV RNA if it's something that I'm worried about, especially with their history of unprotected sex, or I may bring them back in a couple of weeks and repeat the screening test to see where we're at. Okay, but of course very important to make sure that you know their status starting out because when we treat active HIV infection, we treat with 3 drugs, and of course Truvada is only 2 drugs, and we worry about development of resistance. So always at the back of your mind, just do a quick symptom review, signs and symptoms, make sure they're not in that window of seroconversion. So step 3. Starting PrEP. So we document a negative HIV test. We assess them for the signs and symptoms, which we just spoke about. Sexually transmitted infection screen, also very important. And just remember that it has to be done at the site of exposure, and that's why it's so important to ask what types of sex people are having. So is it oral sex? Is it anal sex? And if that's the case, you may want to screen at those sites. You may want to do a rectal swab. You may want to do an oropharyngeal swab. And remember, we're looking for things like chlamydia, we're looking for gonorrhea, we're testing for syphilis. Renal panel, very important. So creatinine clearance, at least greater than or equal to 60. And this is important again for the tenofovir component of Truvada. The hepatitis B screen we spoke about, whether we're going to vaccinate them. And pregnancy testing is important, not only testing, but also assessing future considerations. Are they planning to get pregnant? Okay, it's always important to have that discussion at every visit. So a quick overview. This is a chart that I made up myself, just in terms of what we need to be thinking about. So remember, at baseline visit, we always are getting an HIV test, and we're assessing for signs and symptoms. We're also getting a pregnancy test. We're testing them for hepatitis B. We're checking their kidneys, and we're doing a STI testing. Okay, so we're actually doing swabs to screen them. When they come back to see you in 3 months, you can see that some things are always going to be stable in terms of we're going to be doing them every time they come to visit us, okay? And that's the HIV test and the pregnancy test. So those two things are done at every visit. Regarding STI testing, it kind of alternates every 3 months. So at every 3-month visit, it's going to alternate. So at baseline, you did the actual screen. At 3 months, you can do a symptom review. So ask them if they have things like discharge, any ulcerations, any warts. And then the following time you see them, you can actually do the physical testing. For renal panel, if you do it at baseline at 3 months and it's normal and stable, you can actually skip to monitoring every 6 months. For hepatitis B testing, we like to do that at baseline. And as I said, pregnancy testing, not only testing, but also assessing intent for pregnancy. We like to do that essentially at every visit. So there are so many resources out there on PrEP right now that we can use. Lots of charts, lots of tables that, you know, depending what your preference is, may work best for you. And of course, you can make your own charts as well. This is one that I particularly like. It's from the CDC. And again, you'll have access to all these slides at the end of the presentation, so you can look up these references and print them out for yourself. But I particularly like this one because it's short, it's to the point, it synthesizes all the information in terms of who are your at-risk groups, you know, are they clinically eligible, what you need to order, and what you need to order at every visit. So this is one that I particularly like to use, and one that we use actually here. And remember, at every visit, you're seeing these patients every 3 months. Conversation is an important part. It's not just a matter of ordering labs and ticking off boxes. You want to make sure that they're taking the medication, okay? So are they taking it every day as they should be? You want to talk to them about risk reduction, because remember, PrEP is part of a comprehensive prevention plan. So are they using condoms? Are they asking about partner's HIV status? Are they having any side effects? And we'll talk about that on the next slide. And risk assessment. So do they need to continue? Can we stop PrEP? Has their situation changed? Maybe they've entered into a stable relationship and it's not indicated anymore. Okay, it's important to ask about that. And then, of course, we do see them every 3 months. I tend to see my patients, even though I'll see them every 3 months, I'll actually call them about a week or two after starting PrEP, just to make sure that they're doing okay, that there's no issues with compliance, and that there's no side effects. So important on the outset, I think, to check up on the patients and make sure that really they're doing it okay and using it as it should be used. So side effects are really important to talk to patients about it, because if they have these symptoms and they're not expecting it, they may, you know, suddenly stop the medication. Common things that we see would be things like headache, abdominal pain, poor appetite or weight loss, and we call these startup, which means that on the outset of starting the medication, they may present, but over the next 1 or 2 weeks, they may simply just ebb out and go away. Renal impairment is something that we've talked about a lot in the presentation. Fanconi syndrome, which is a defect of the renal proximal tubules, so we start to lose electrolytes and nutrients. And then the ones with the star here may be a bit more severe. Side effects including lactic acidosis, severe hepatomegaly, which is enlargement of the liver, or steatosis, which is fatty liver, and a severe flare of Hep B, specifically if we suddenly discontinue the Truvada. Again, many resources out there. The PrEP REMS website, sponsored by Gilead, actually has a lot of information, not only for providers, but also for patients. They have lots of quizzes. It's written in a very kind of easy to follow way. I particularly like the site because they have a lot of resources that we can use in our clinic on a day-to-day basis. So the PrEP agreement form is here, and it's almost like a contract that they have available, which the healthcare provider can sign, the patient can sign. It delineates what each group is responsible for. And I think it's a nice way to kind of keep everything neat and tidy. You can print it out, sign it, and you can scan it into their electronic medical record. So step 4, as we said, when to stop PrEP. Of course, if someone is HIV positive, if their creatinine clearance falls below 60, we begin to worry about the effects of tenofovir at that time. If they're just not taking it, okay, so poorly compliant, they're not doing their refills, or they tell you they're taking it, once or twice a week, PrEP is not going to work, okay, and we saw that again in those studies at the start of the presentation. And of course, if their situation changes, they're no longer at risk. Maybe they're no longer in a relationship, or maybe they've entered into a stable relationship. This is a question that comes up a lot in terms of special populations. So we think about pediatrics and pregnant women. So do we license PrEP in the pediatric population? So as of now, there's no FDA approval, okay, for indication for those that are 18 years and younger. And the reason for this is that we just don't have the data yet. So there are studies that are going on looking at PrEP indications in the pediatric population. However, as you can imagine, there's lots of issues with ethics, with parental consent, and so we just don't have data on that yet. And I guess the primary concern here is what effect is the tenofovir going to have on the developing bones of young children, okay, or young adults. So as of yet, not an indication for use. Pregnancy is a little bit of a gray area, and so there's no kind of hard yes or hard no. It's definitely a discussion that has to be had with the provider. It's an assessment of risk, essentially. So if you can imagine a serodiscordant couple where the woman is HIV negative, her partner is positive, they want to have a baby. So of course the risk of infection and transmission will increase during this time, okay? And of course, if the mother is infected, you worry about perinatal transmission, so the risk may be substantial there. Certain things to think about, though, that all those studies that were done that I showed earlier on in the presentation, all those women that became pregnant during those studies were actually withdrawn from the trials. So long-term data, we don't really know the effect that tenofovir has, or the fact that Truvada has on patients that are HIV negative who are taking it. Truvada is a Category B drug, which means that there's no adverse effects seen in animals. And of course, patients that are HIV positive, that are on Truvada already and pregnant, we keep them on that medication for the course of their pregnancy. So there's kind of arguments for both sides. Again, it's not a hard yes or a hard no. It's definitely a discussion with the provider and really kind of an outline of the risks and benefits. Common questions that patients may ask you when they come to see you in their clinic is, will you be monitoring drug levels while I'm on PrEP? And the answer to this is no. So of course, during the trials, during studies, they do look at concentrations, okay, and the ones I quoted before where they, it says concentrations in blood and cells and various tissues. As a general rule, this is not done in the kind of the day-to-day population. There's very few centers that actually run these levels, and it's very cost intensive. So as a general rule, we do not monitor drug levels. Very other common question is, could Truvada affect my bones? And so the answer to that is yes. So Truvada, specifically again, the tenofovir component, has been known to cause a decrease in bone mineral density. However, I will say, specifically if we're using the IPEX trial as an example where they studied this effect over time, it did actually lower bone mineral density. However, at the conclusion of PrEP, when patients stopped, that density recovered fully. Okay, so it's something that is reversible. And then the other question that I get quite commonly from patients, especially when I start them on PrEP kind of from day one, is, well, how soon will I be protected? So the information for this is actually, the data that we have actually comes from MSM studies, okay, in terms of what concentrations do we have in rectal tissues. It's estimated that it takes about 7 days for PrEP to build up adequate concentrations in these tissues. Again, this is for males, okay. What What timeline for females in terms of concentrations in cervical tissues, vaginal tissues, we don't actually know. And so this is kind of a segue into the next point here is, is there sex differences then in PrEP efficacy? And this was a study that was done to basically assess that. So about 15 healthy volunteers were given a single dose of Truvada for PrEP. And over the next 14 days, what they did is they analyzed the active metabolites in various tissues. So they looked at rectal tissue, okay? They looked at vaginal tissue and cervical tissue. And what you can see here is that there is quite a bit of variation in terms of how it concentrates in various tissues. You can see in the vaginal and cervical tissue there's quite a bit of fluctuation, and then towards kind of the, moving out from day kind of 7 onwards, it actually drops off quite a bit. And so the issue is that we know that, adherence is key and it needs to be taken every day, but perhaps is adherence even more important in females, okay, or in women, just because we're unsure exactly how the concentration varies in these vaginal and cervical tissues. Okay, so just be aware that there is quite a big variation between men and women in terms of how things concentrate. So moving on to financial considerations. So PrEP is expensive, okay? It's about $13,000 a year. But the good news is that we do have assistance for those with and without insurance. And again, I'll remind you that all these slides will be provided to you at the end of the presentation if you want to look up kind of numbers and websites. But for uninsured patients, we have Gilead's Medication Assistance Program, and there's the number and the link over there. And for, we also have the PrEP Exposure Prophylaxis Drug Assistance Program, or PrEP-DAP, that we can also use to get help for our uninsured patients. Okay, if patients are insured, we have the Gilead Copay Coupon Card, which is something that I frequently use, and there's also the Patient Access Network Foundation, which can also provide some form of aid. Quite often, it just involves filling out, prior authorization forms, which are very basic, very easy to do, and it's easy for patients then to get access to these medications. For those of you that may be involved a little bit more in billing, so the updated ICD-10 codes that you may want to use when you start charting, here's a list of them right here. Of course, I don't think people are going to memorize these, but you'll have access to these to look up and reference after. But we do have lots available in terms of how we can chart and code and bill for these. Some CPT codes, if we're talking about prevention counseling in terms of how much time we spent, you can see the numbers listed here, and again, you can keep them from your reference kind of moving forward. So just to wrap up now, talking about trends. So, PrEP use, what are we seeing today? So this is an article that was in the Journal of Clinical Infectious Diseases back in 2014, and at this time they surveyed infectious disease physicians from the US and Canada to get their kind of attitudes regarding PrEP and their prescribing habits on PrEP. And they were polled, and they found that 74% of physicians, okay, ID docs, supported PrEP use, whereas 12% did not support it at all. 9% had prescribed it in their practice, 43% had thought about it and would, but had not, and 14% said that they would not prescribe it at all. So when looking into that a little bit more, in terms of what exactly was worrying people, they found out that the key issues were really adherence, the risk of resistance, okay, specifically if someone got HIV infection, cost, reimbursement, okay, toxicity, so thinking about kidneys, thinking about bones, and really the amount of data that was out there in terms of long-term effects that PrEP would be having. How are we doing across the states? So reassuring to see that the South actually leads in terms of PrEP prescription, and of course this is very important considering that if you remember back to the slide at the beginning of the presentation where we see that Florida and Louisiana are really having some of the highest rates of HIV infection across the United States. Okay, so it's good to know that there's a big shift towards prevention. Also the West Coast, 27% of providers there, and followed next by the Northeast, and coming in last is the Midwest. So a good bulk of the population being on PrEP coming from the South. And this is some, just to kind of highlight in terms of how PrEP has really taken off over the last few years. This is a Gilead study done by Stacey Bush and her colleagues. And they basically polled about 82% of pharmacies, so electronic data from pharmacies across the United States, that were using PrEP as a, using Truvada as a PrEP indication. And you can see how things have taken off. Specifically, if you look at the end of 2013, kind of the start of 2014, up into the first quarter of 2015, there's about a 332% increase, which is quite staggering. And we'll talk about, who's going to make up the bulk of these users. Initially, when PrEP started out, it was women that we see that were more kind of using it. Now we see this trend has shifted quite considerably to be males. But definitely PrEP is on the upswing, which is great to see, reassuring to see. And hopefully we'll be getting more data soon to make sure this trend continues to go up. So another poll question. The majority of patients currently using PrEP are 1. African American heterosexual males, 2. White gay men, 3. African American gay men, or 4 white heterosexual males. And I'll give you all a moment to think about that. I don't know if we're polling here exactly.
Yeah, we're having a little bit of technical difficulties with the 5th poll, sorry.
No worries. So I'll just give you guys a moment to think about that in your head, and then we'll move on. Okay, so the correct answer here is actually 2, which is white gay males. Okay, so that's number 2. So what do we have in terms of data and attitudes and trends? So there's about more than 49,000 patients currently using PrEP, and this number is actually probably grossly underestimated. Most, as we got from that poll question, are white gay males. In terms of the overall distribution, according to race and ethnicity, we see that it's actually the Caucasian population at 74%, followed next by the Hispanic population at 12%, and African Americans comprising 10% of those currently using PrEP. Initially, at the start of 2012, we saw a trend where there was quite a bit of women primarily using it, and now that number has actually dropped down to 11% in the first quarter of 2015, as really the gay population, the MSM population, word of mouth has spread quite considerably amongst them, and they really are at the forefront now of PrEP use. As a rule, we saw from the data that African American women were 4 times less likely than white women to start PrEP, and about 8% of people are younger than 25 who are currently using PrEP. And so if you think about some of the epidemiology slides I showed at the beginning of the presentation, you see that these trends don't reflect the current epidemic. Polling some attitudes, there was no difference in willingness to use PrEP between African American and white gay men. Okay, so the intent was equal amongst both, but that higher education, higher incomes, access to health insurance were really positive predictors for those that were actually going to go ahead and use it. So in summary, what you can think about then from this data is that it, as I said, it doesn't reflect the distribution of our HIV epidemic. We said that the African American male population, specifically the MSMs, were really at the highest risk, and if we look back to the last slide, they're the ones that are using PrEP the least. PrEP services may need to be racially focused, and culturally relevant. And just remember that willingness does not translate into use, and that there are racial differences in healthcare access that we may need to think about moving forward. So kind of wrapping up, just to give you an idea about prescribers, and I like this slide and I'm happy to see this data, that it's really the internal medicine and family practice physicians that are getting the word out about PrEP and that are managing and kind of taking care of this. And I think that's great because these are the docs that are going to be seeing their patients quite often, have that close relationship, and those frequent visits. Infectious disease doctors, nurse practitioners, and physician assistants, of course, also play important roles. But really it's the family practice internal medicine where the word can really get out there and that we really try to promote PrEP for them. So just to kind of round off, I think it's important to have the discussion. PrEP is definitely not right for everybody. It's a great way for HIV prevention. It's a great strategy, but it may not be the best fit for your patient. I think it's definitely worth the discussion if you have a patient that you think may be a candidate or could potentially be interested. But just remember there's a lot of factors that need to play into this, and so it may not be the best fit, but it's definitely worth the discussion. Okay, and so this brings us to the conclusion. I'm more than happy to take any questions or comments. You have the PrEP resources here, which is what I used for this presentation, but there's also a wealth of information in all of these, specifically the top one here, the Truvada PrEP Prems. Really, really good information for providers. There's quizzes that you can take, good documentations, and of course AIDS Info, the CDC, have great guidelines in terms of prescribing, follow-up, and things like that. So I open it up to you for any questions or comments that any of you may have. I'm more than happy to answer whatever I can.
And Dr. Mueller, I can start us off with a couple of questions that have come in on that Q&A pod. And again,
Sure.
just to reiterate, any questions that you all would like to submit on the Q&A pod, the only people who can see those are the presenters and myself. So the other audience members won't see them. If you'd like to type a question in that pod right below the PowerPoint presentation, is the best way. So one question that's come in discusses using PrEP as a means of preventing HIV transmission when couples, which one person's positive and the other one's negative.
Mm-hmm.
I just wanted to just kind of see if you could discuss that scenario, how PrEP could be used for a couple in that sort of situation.
Yeah, absolutely. So, so we refer to those couples as serodiscordant couples, where, as Taryn just said, one partner has HIV, the other partner does not. If you think back to, again, those studies that I mentioned, one of those studies was done exclusively in serodiscordant couples, so it is licensed for use in those couples, and it definitely has a role in prevention. Because if you imagine that, even if they're in a committed relationship, if the partner does have HIV, they're having intercourse, even if the partner with HIV's viral load is, less than 20 or undetectable, definitely the risk of transmission is low, but it's not zero. And so PrEP can definitely play an important role there. And there are lots of patients that I see in my clinic that are in that situation where that they're in that serodiscordant relationship who come looking for PrEP and asking about PrEP. So definitely it does apply to that population.
Great, thank you. And another one here is, let's see, it says, asking if it's okay to dose the Truvada for renal disease, say if the creatine initially was over 60 but then declines to 45.
Yeah, so that's a great question. So this is not something that we dose adjust for. So ideally, if if they start off with a good creatinine and suddenly it begins to kind of trend down a little bit, we're assuming it's probably related to that tenofovir component, especially if there's kind of no other culprits in there. And in those patients, I do really recommend actually stopping PrEP or seeing if I can perhaps find any other culprits and maybe eliminate those. But we just typically do it. It's meant to be as a once daily dosing. And if you can't take it in that formulation due to renal dysfunction, it is recommended that if your creatinine clearance does fall below 60, that you really do stop it.
Okay, I've got a couple more here. Someone wanting to thank you for the great presentation and asking if the data for the types of providers that you had mentioned in one of your slides, like infectious disease specialists, generals, et cetera, that offered PrEP, did that come from the Bush study or from another source?
So that came from another source. So this data is a little bit older than the Bush study. And I actually, I don't know if that's this particular information has recently been updated, but it wasn't from the Stacy Bush study, no.
Okay, we've got another here. Funding for prescriptions can be obtained. What about for labs and physician visits? Are there any resources available for those?
So that's actually a good question. I actually personally don't know, to be honest with you, off the top of my head, about kind of the follow-up visits and the labs. That's definitely something that needs to be checked with the insurance. You know, what I did mention with those sites, it really is for the medication per se. But I'm not sure exactly in terms of, you know, lab coverage specifically. Most of the patients that I see, you know, I may fill out those forms to help them with the medication itself, but their insurance seems to be covering the labs and the visits, 3 monthly visits.
All right, another question here. What are the reasons patients most frequently cite for not adhering to or beginning PrEP?
So I'll be honest, actually, the patients that I see in my clinic that are on PrEP have all come to me wanting to start it. Most of the patients that I've seen are, you know, homosexuals, so gay men, and they've heard about it from their friends within their community, from the news, and they actually come in very excited to start it. I have had a few patients starting it that have gotten side effects, and that was an initial deterrent. And so that's why I actually strongly urge that once you start patients on medication, you know, instead of waiting for that 3 monthly visit, you actually follow up with them in about 1 to 2 weeks, let them know that what they may be feeling is normal. But aside from that, most patients that come into me, I have to say in my own experience, they've actually been pretty committed because they've been wanting to start it.
I don't see any other. We've privately responded to a couple questions, and I've sent that feedback to them. If anyone else has other questions, you can submit them in that Q&A pod. And we're just clearing out the queue, making sure we got everything. Okay, so I think, oh, hold on 1 second, right as to close it out, one more question came in. When a serodiscordant couple is positive, one is positive and he is negative, what would be the time waiting for medication? It says, what would be the time waiting period for medication to be in the body for them to be protected?
Okay, so again, whatever data we have on this is from the measurement of concentrations in rectal mucosal tissue, and we said that was about 7 days. In terms of the exact time when PrEP begins to be effective, we don't know, but as a general rule, we do say it's about 7 days.
Great, thank you, Dr. Muller. Okay, so if any other questions can come in after that, we'll make sure to kind of either respond to you privately or send an email out if it is an email that can be put out to the rest of the group. So as a reminder, a copy of today's PowerPoint presentation can be downloaded from the Files tab. It's located on the lower left-hand side of the Adobe Connect room. Don't forget to check the email that you use for registering today. The evaluation link for this webinar is in there. Your evaluation is critical in helping us provide valuable feedback to our speakers. It allows us to also continue these sorts of opportunities free of cost to you all. For those of you needing certificates as proof of participation or for self-reporting to your own continuing education agency, please reply back to that evaluation email request that you get. Once you complete the evaluation, we'll be happy to send you a certificate for that. And actually, Dr. Mueller, one more question's come in.
Sure.
For vaginal and bloodborne protection, is it 21 days before Truvada Protect?
So definitely for if we're thinking really about vaginal exposures and women, I don't know if we can exactly say it's 21, but it's definitely going to be more than the 7 days when we think about rectal tissue.
Okay, great. And we'll leave the room open for a little bit so if anyone has other questions to kind of get those in, and we'll make sure Dr. Mueller addresses those. And like we said, you should receive an evaluation link via email. There's also a link right there in the pod section in the bottom right-hand corner of your Adobe Connect room. So thank you very much for hanging with us today through your lunch breaks. Thank you, Dr. Mueller, for being here with us today to answer some great questions for a great presentation.
Absolutely. Thank you, everyone, for your attention. And like Karen said, happy to answer any other questions that come in after privately.
Great. Thank you, everyone.
Thanks.